Good morning, all my friends over here in India, and good evening to all those in America. And welcome to the 96th edition of this continuing medical education program on COVID-19. As you know, that we are fast approaching 100, and on the 100th one will be a very exciting one, I'm sure. And meanwhile, this time we have changed the format a little bit in the form of an interactive session because mental health has become an important aspect in COVID-19 management. As you have seen, right from the beginning, we have been basically concentrating on the contemporary issues which are present at that particular time, which are posing challenges to all of us. And at this moment, we always, right from the beginning, we have been seeing the mental health issues. So we had many sessions on mental health, and perhaps we have not concentrated enough on mental health here in India as much as they do in America. Though Dr. Bush Kavuru has been telling us repeatedly that we'll have form a part of a group so that we can help more number of people. So before it explodes into an epidemic proportion of this mental health problems, I think it's always better that we have some understanding as well as we percolate the information into the society so that we can reduce the morbidity as much as possible. So we have friends all around. We have anecdotal experiences as to how their patients are feeling and how they're suffering. But it's always important that we put all their experiences together. So we have a good number of doctors who have actually dealt with the patients, who have dealt with their families, and have their own personal experiences, but do not know what to do. So this is a forum which addresses that. So we have taken Dr. Vijay Shekhar, who handled the CSR block here during the COVID second wave. We have Dr. Prem Kumar, who has been in the state expert committee, who has been dealing with all aspects of the COVID. And similarly, we have Malleswara, who has been practicing in the periphery and who has been a very intent listener and a very good participant in this forum, who also comes up with real life scenarios. So we thought we'll put all these together and give some sort of information to everybody so that they would know as to what is to be done next when they find such a patient, where to refer, or can they handle themselves. There may be some specialities where they can handle themselves, like the internal medicine. So we have to give them some opportunity to see that these mental health patients or the patients, post-COVID patients who have some mental health issues are not left behind. So with that intention, I requested Dr. Kairam to take lead in having this particular session today. And over to Dr. Ram Kairam to reintroduce Dr. Bush, because some of the people might have joined afresh this time. And at the same time, it's always good to know about our own friend, what he has been doing over a period of time. So over to Dr. Kairam.
Thank you, Dr. Sudhakar. For some of you know already, others may not. Dr. Bush Kavuru is a graduate of Andhra Medical College, has been in private practice or practice of psychiatry in Virginia for many years. I've been talking to him a lot recently. Well, I've only gotten to know him in the past 1 year, although I knew his name for a long time. And even though he may not be sitting in one of those university medical centers, department head of this or that, I have come to appreciate a man who's very attentive to what's going on in the community, mental health issues during this acute COVID epidemic, and also he's connected to Andhra Pradesh. He knows what is going on. So I asked him to please consult with us as though we had consultation liaison psychiatry. Some of you may not know that in the American hospitals, within the Department of Psychiatry, there's a division called Consultation Liaison Psychiatry, where the psychiatry resident or the fellow would come onto the acute medical floors when there is an acute psychiatric problem, an impending death, or a distraught patient, family, etc. We don't have that in India. I don't know about the big institutions. So in the absence of that, how do we deal with such a severe disease as COVID impending death, grieving, bereaved families, father of the family dies, leaving behind children, children are dying, and there was tremendous difficulty March, April, May. So I was going to ask Dr. Kavuru to moderate actual in the field, from the field questions posed by three people who are heavily involved with the acute situation, although it may be abating right now. So I must admit, I don't know all of Dr. Kavuru's academic appointments, etc. I never asked him, but just the fact that he is an AMC graduate is very important for Dr. Sudhakar and I, as I helped him to identify people who are able to speak and are knowledgeable in their field. And so at this point, I'm going to ask Dr. Bush, Dr. Kavuru to begin. Welcome, sir. Proceed.
Thank you, Dr. Kairam, and thank you, Dr. Sudhakar. Just humbly to share that after finishing my medical school here, Andhra Medical College, I went to All India Institute of Medical Sciences in Delhi. I did my psychiatry. Then I did my residency and fellowship in geriatric psychiatry at University of Pennsylvania. Last 10 years, I'm an associate professor with Virginia Tech Kirill School of Medicine. And I had an opportunity to see psychiatry from the cradle to the grave, from child psychiatry to geriatrics. And I have been visiting Visakhapatnam, and I'm in close touch with a lot of my classmates. And I appreciate this opportunity to come back again and share some of my experiences with the experts there, all of you. So in that context, I think first time, I want to share that I'm a consultation liaison psychiatrist for a decade. So I worked in the ICU setting. I worked in the hospital regular floor setting. And I also worked in the inpatient setting in psychiatry. Right now I'm doing outpatient. So I talked to my colleagues in India, and I thought I could share what we know from here and see what the best we could do. My first talk has been on acute COVID initially 6 months ago, when we were having a lot of acute patients, and we talked in terms of what could be done in an acute medical setting. Then 4 weeks ago, I came back and we talked about the long COVID symptoms and again, mental health symptoms. Now, what I'm hearing is that this is the long-term effects of this pandemic, and what would be the issues going forward if we have another wave, and how to handle and learning from the lessons and going forward. So with that, Dr. Kairam, whoever is the, I think, wanted to share the first, and then we can start the discussion. Dr. Shekhar?
Yes.
Do you want to go ahead?
Yes. Good evening, Bush, and good morning, all dear friends in India. Thank you, sir, for giving me this opportunity. And Bush and all others. Yesterday, I had an opportunity. Actually, I have been to a function of one of my friends' family. Actually, he was my college mate. In the last year, second wave of COVID, he got admitted in CSR block with severe COVID. No, my friend, he was a botany lecturer. He lost his father while he was in the hospital CSR block itself. And within few days, he lost his sister also. And his saturations deteriorated drastically. In spite of all the efforts, he could not be saved. So I lost my friend. and subsequently also his mother-in-law also passed away. So this is a situation where 4 members of a single family lost their lives in a span of less than 1 month during the peak time of second wave of COVID. So it was a very disheartening for me to attend the function of my friend's daughter yesterday. So everybody was very in a sorrow mood. There is no joy of that function anyhow. So such situations are very many. And what I look at is the perspective from the patients and their patients' family side, the psychological stress or the apprehensions or fears about the disease and the long-term consequences. These are all on one side. And the other side, the work pressure or how to handle all these cases. See, for example, in the CSR block itself, the entire block, all the cases in Visakhapatnam are predominantly neither in the CSR block of KGH or the Visakha Institute of Medical Sciences or the chest hospital, ENT hospital. So these are the major things, all the government settings, apart from several COVID care centers and other private hospitals. So most of these healthcare providers, starting from the paramedics, the regular duty medical officers, and the consultants, the physicians, the anesthetists, and the pulmonologists mainly, all these, in addition, the administrators also. I think all of you know how much efforts as an administrator Dr. P.V. Sudhakar has to put in. Just to get the CSR block functionalized itself, he has to work there from morning to almost 9:30, 10:30 in the evening. So there was a tremendous stress or work pressure in the healthcare workers also. So this is how I look at from the patient's perspective and the healthcare provider's perspective. Sir, to begin with, I share one of the case. I have shared some video with Dr. Ram Kairam and Dr. Bush, and many of our colleagues in India might have seen that video also. A young lady, maybe around 30 years, she was admitted into ICU, and all of a sudden she started walking briskly and went near a window of that ICU floor and attempted to jump from the height. So immediately by looking at that, the nearby patients were shouting, and the staff nurses and the duty doctors, they came running, and ultimately the 4 or 5 personnel have to stop her from jumping from the window, and they have to pull her out forcibly, and they come. When asked, she was telling that she was very apprehensive and she will be dying if she is kept in the hospital, and she was insisting for discharge from the hospital immediately. So it was a situation when she was admitted in ICU and she requires the medical treatment, but seeing the patient's condition, the consultants have come, they have counseled both the patient and the family, and ultimately she was discharged and was at request, and she was handed over to the family, and she was taken care. So, Dr. Bush, I would like to ask you, this is one scenario, and prior to that, we had witnessed 3 deaths in the same premises, where the people have jumped from the top floor. The ICU was in the 4th floor. So immediately after the first mishap itself, we have taken every precaution from the administrator side, put the obstacles and tightened the security and all. But still, 3 such incidents have taken place. We could prevent the 4th one. So can you analyze the psyche of these patients and what might have precipitated this in spite of their regular medical thing, and what could have been done to prevent that, and how to go about in future to prevent such dilemmas or such feelings in the depressive feelings in the patients. I would like your comments.
Thank you, Shekhar. First of all, I'm very sorry that you lost your friend and the whole family succumbed to COVID. And it's very difficult situation. And that is one of the things is a main worry throughout the world. Especially in the pandemic, people lost their loved ones and they're not able to say goodbye. And there was no proper closure. And so now the anniversaries are coming, and you would have sometimes what we call anniversary reactions. And how to help the grieving families is going to be a burden, but who's going to care for them? In our system in India, we have very limited number of psychiatrists, and we don't have psychologists or the social workers to do a lot of counseling. And whoever is the primary care force we have, they're very busy, and some of them are comfortable treating depression and anxiety. But when it comes to the grief, they are the ones actually providing a lot of support. As senior physicians in the primary care setup, they're able to counsel and try to instill some hope in them. That is how it is happening. And as I said, I in my own family lost 3 members last year. And I think my cousin, he passed away, and everybody is going through the same thing in terms of grief. But one thing any person can do in the grief is listen to the patient if they are talking about it. It takes a long time, and we try to sometimes reassure them things are going to be okay, move on. And these sometimes will work, but not necessarily in every person. But one thing is, if you have seen a patient, the grief is becoming complicated. A lot of these people, because of lack of any other option, because of the life pressures, or because of they have to take care of the rest of the family, they keep moving. They may have issues with insomnia, and they may have depression clinically. But if the depression is getting to the point where they are not becoming functional, they're not able to go to work, they're not able to take care of the household issues, or it is affecting their marriage. In those situations, probably the grief needs to be addressed. And how a primary care person can help is still a challenge. If there is a complicated grief where people don't want to live, and if they are non-functional, I have actually developed a toolkit 5-6 years ago to give to our primary care, where if the primary feel comfortable, you can start counseling along with an antidepressant. One of the antidepressants commonly available in India is escitalopram, called Nexito. But I don't know how many of the primary care are comfortable doing it. So with the grief, it is being there, being supportive of them. And I think I was talking to one of my Malaysia yesterday, and he shared his experience. And one thing is, we always try to make them look at the role they have left to play in life. Like with your own friend situation, the daughter is there, and she is grieving, and she's grieving as a daughter, but at the same time, she has her own life to move forward. And I would rather tell these grieving people, you will never forget the individual whom you lost. right now, the challenge is when we are thinking of him, we are all feeling sad. But you want to come to a point where you will be able to remember them 5 years from now with a smile on your face, because you will never forget your friend or again, rest of the family. So where you can take them in the grief processes, they will still remember them, but probably with a smile on their face, memorizing the good things they had in life. And again, I think the concept of our Indian philosophy could be helpful if we can use those kind of situations. And if you have a concept of heaven, and if the person is good, we can definitely share with them that your loved one is in the right place. Okay. So some of these are simple counseling techniques, anybody can use it. So your second question was the providers who were taking care of them. And basically you were talking about the burnout they have suffered while working in the COVID units. And I think before Dr. Murali Krishna, I think he came and he has given some talks about the burnout issues. But currently, if you look back, if the cases are low, what would be is how these providers, like, you met your friend, and if you're meet somebody else and you start talking about what happened, it is almost nightmarish situation. So not only the patients and if they have families have this anniversary reaction, but it is also possible for the providers after a year, 2 years, when you think about some cases will be really, really like, even if you wanted to erase them, they won't go away. Like, you talked about the patient with the suicide. And if you are the provider there and you are running to catch the patient, and if she jumped out of the window, that will stay with you for a while. So handling this probably would be what we call it, patients may, the providers, any person who has been, it could be a what you call, need not be a physician, it could be a respiratory therapist, or it could be a ward boy, it could be a nurse, anybody, all of them may have issues in terms of having pedikal raavadam, sarga nidra pattukovodam, and flashbacks, and that can lead to anxiety symptoms, anxiety attacks like that. And if they're persisting, we call it post-traumatic stress disorder. So the initial burnout at one time, now even though the cases have come down, some of the providers can have these symptoms of PTSD. And again, how would you address it? Because we don't have so many providers there. Not everybody is going out and talking about it. Because in India, unfortunately, the issue with the stigma we have. Dr. Sudhakar was mentioning, going forward, mental health is a huge issue. What can we do about it? When we have all these symptoms are coming out, how are you going to address it? People are very easy to go and say a broken fracture, and that guy has a kind of a cast on him. He's happy to show to other people the cast and get their autograph on the cast. But if somebody is depressed, having panic attacks, somebody is having anxiety attacks, they're not going to tell anybody, hey, I had a panic attack, I had an anxiety attack, I'm worried. They will hide it. Nobody will share it. The reason, one of the things is that already people from NIMHANS and Ranchi and other, they're looking into this. Mental health in India seen as almost like an only psychiatric condition. Everybody thinks in picture it is whether it should be schizophrenia or a major bipolar disorder, but that is not only the mental health issue. Anxiety and depression is the most common, and most in the general population has it, but nobody can share with it, because if they think went to a psychiatrist, they think they have a major mental disorder like schizophrenia, and they think it will be a moral defect. Sometimes they think it is a weakness. I'm not strong enough to be. So from the societal perspective, we got to rather educate and normalize some of these reactions. Because if you look, this is all stress. Since the pandemic has started, everything is stress for the provider, for the patient, and for the families, for the survivors, and for everybody. So stress is something everybody has it. It is a normal thing. So if you normalize some of these and then say your anxiety or a depression or a panic attack is a reaction of the stress, if you seek help, it will get better. And for the majority of them are non-psychiatrists, how do you look at this? Like, we talk about diabetes, we talk about hypertension. In the early diabetes, in early hypertension, if you make lifestyle changes, definitely you can keep it a little bit more. And similarly with anxiety and depression, if you rather give a concept of it is a kind of a disorder of the brain, I would say brain is the hardware, mind is the software. So if we approach it that way, people look at mental health issues more common as like diabetes, hypertension, there will be less stigma, less judgment. Patients and even the providers will seek help to get over the burnout issue. The third one you mentioned about is the case of the lady who jumped out of the window. KGH is a general hospital. It is not a mental health hospital. It is not a mental health establishment. Even in America, general hospital wards are different from psychiatric wards. If the patient is suicidal, if they're in an ICU setting, they may put them in what we call suicide watch. But even then, once they get better, if there continues to be suicide, they usually get transferred to inpatient psychiatric ward where there is more resources, more observation. The units are built to prevent these kind of incidents. But in a general ward, it is not easy to do. And now, as you mentioned, it is a lot of stress as a provider, as an administrator, because everybody says you are accountable. The patient is with you, you should have done something. I think this is more of a system-wide issue, administration-wise issue. But only one thing I can share is that when I was working in All Institute of Medical Sciences, when I was doing my residency, every psychiatric patient has to be admitted with an attendant from the family. So for every patient, we had one person by the bedside. In the COVID, you could not do it because there are isolation units. But I think, hospitals have to come up with some kind of a policy or a standard operating procedure where providers feel that they're doing what they can do and probably get some other, have a psychiatrist as a consulting. Again, that's where we have to involve the mental health in the medicine. We have to integrate a little bit of that in the general medical hospital setting, but it is, as far as I know, that's not there for us in KGH. So those are the three things, Shekhar, you mentioned. Does it help? Does it answer your question? They're very complex questions. I cannot get in details and give, but
Yes, Bush. And thank you for the hello. Am I audible?
Yes. Yeah.
Yes, thank you for your discussion and analysis on that. Yes, as you said, the patients may be in severe acute anxiety, and allowing some of the attendants at the patient's bedside may definitely improve. So probably that was practiced here with most of the OPG patients. Initially, no attendants were allowed, but subsequently, when the pregnant lady comes in for the delivery, a COVID-affected pregnant, then they thought better to allow one of the attendants with a PPE kit, and then that way some of the stress in the pregnant woman could be relieved here also. So thank you for that.
Again, you mentioned one followed the other, 4 or 5. We call this copycat suicide kind of a thing. But I think with the pandemic, we also talked about there is another pandemic of panic. Simultaneously, there is a panic pandemic. And I think, a lot of ICU physicians probably, they have seen it more. And there's an impulsive action. So getting a good psychiatric history sometimes helps. If they have a history of mental illness, probably you will say, oh, have somebody of family member there. So you were asking, how can you prevent it? Is only by screening. If the patient has already existing mental illness, and if we make it part of our evaluation, medical history, if you have any mental health issues, have you ever attempted suicide? If they say yes, probably that's a person would need a little bit more of an observation kind of a thing. But I think in our system, I don't know how it is possible. Probably Dr. Prem Kumar can throw some light in terms of ICU and these kind of situations.
Good evening, all of you. Good evening, Bush. Welcome to this meeting. And yesterday, when I received a call from Dr. Kairam that you have to share some stories, I drew blank. Actually, when I was in the clinic, actually, right at that point of time, I was in a PPE visiting my friend's wife who happened to be an asthmatic and contracted COVID. So I drew blank and I thought it's, altogether a different kind of fish, kettle of fish for me. Because all these days I was speaking about oxygenation, NIV, ventilations, or treatment protocols. But all of a sudden, when I was asked to talk about something, to share something about the psychiatry. But then once I reached home, I just relaxed back and thought, what happened in my practice these 2 years? So I had to share a few things. One, as a administrative capacity perspective, and another as a practicing pulmonologist. As a practicing pulmonologist, post-COVID, I have seen hundreds of patients coming with, sense of, they used to complain shortness of breath, chest pain, palpitations, and insomnia. So I have almost thoroughly investigated everyone, the chest pain, including a cardiologist evaluation, TMT. Some people underwent angiograms. Nothing was there, but still they used to visit me again and again that I'm having chest pain. Likewise, shortness of breath. Every investigation was done to rule out the organic causes of breathlessness. Still they used to visit me. Lot of young patients, they used to visit me with palpitations. So we really didn't know how to go about it. And initially when I advised them to go to psychiatrists, so the stigma, they refused. So as you said, what as a primary practitioner, we know escitalopram with clonazepam combination was there. As you said, Nexito LS, Nexito Plus. And people who had palpitations and tremors, we used to give clonazepam with propranolol, that's clonophyt beta, one tablet was there. And then we asked them again, before leaving the chamber, asked them to consult a psychiatrist. As a practicing pulmonologist, this is what happened in the clinics. And regarding acute COVID, actually my assistant professors, associate professors, residents, they used to go inside, and now and then I used to visit. And the things are patients in ICU psychosis, delirium. So initially I advised them to rule out electrolyte imbalances, metabolic encephalopathy, and they had renal problems, AKA, so uremic encephalopathy, lot of diabetic ketoacidosis and all those things. And a lot of problems we have seen are from alcohol withdrawal. Patients, alcoholics, they were admitted into the hospitals, they were administered COVID treatment, but nobody bothered to look at the withdrawal because he was not given alcohol all the time he was in the hospital, those 10 days. So patients became delirious, that probably delirium tremens or what, that alcohol withdrawal syndrome. And some people were panicked because, hundreds of patients were thronging the ICU. And in the beginning, that is in 2020 beginning, tens of patients were dying at a time. So even a lot of people, they didn't get a decent burial. So looking at it, the psychiatric, if someone denies, any one of us denies that we didn't have a psychiatric problem, minor or major, it's a blatant lie that I can say. Every one of us suffered from an anxiety or whatever. So the problem to be addressed is anxiety on the part of administrators, anxiety on the part of the service providers like doctors, assistant professors, PGs and all, because they have burned out. Round the clock they have worked, and without any leaves. All the leaves were cancelled, even for doctors, everything. That's actually, that was demanding. And then problems with the patients who had acute illness and post-COVID sequelae, and some of them are organic and majority of them are, just now I said, all causes were excluded. Still, they used to complain the breathlessness, chest pain, palpitations, diffuse pains over the body like that. And then we failed to address COVID occurring in psychiatric patients. So all the patients admitted into ICU or COVID wards are not normal. Some of the psychiatric patients got admitted, some of the alcoholics got admitted, some of the smoking addicts got admitted. So once they were withdrawn from their medications or alcohol or smoking, they used to behave bizarre. So a lot of issues I am touching here. And then three clinical scenarios. Yesterday I sat back and was thinking what happened. Three stories I'll tell you. One, my daughter's friend's father, he's around 55 age of me, and he got admitted into COVID with some 15/25 score. He was on a non-invasive ventilation. But the next day, I got a call from her that father is behaving bizarre in the ICU, and people are unable to, control him. He's talking. That's what the nurses and doctors attending there complained, that he was, moving here and there, refusing to use the NIV. He's talking whatever nonsense. So then I asked, why this is happening? Is he an alcoholic or anything like that? Then she said, no, he is having medicines for some psychiatric illness. And we didn't tell the doctors there in ICU that he is having them, that problem. So he didn't have those medicines for the last 3 days. That was one problem. Probably this is whether they forgot in a huddle or it's a stigma that they didn't tell to the ICU doctors. That is one problem. Second story I narrate is, I had a 9th standard boy studying 9th standard. His father was a lecturer in a degree college, and father was my patient for asthma. He was consulting for several years. So the father died. So the mother and aunt, maternal aunt, brought that 9th standard boy to me, that this boy is coughing all through for the last 1 week, coughing day and night, and he's feeling breathless. He was never an asthmatic. Earlier, the child also used to accompany his father. Father, mother, and child used to come to Vizag. Father used to show me for asthma, and probably they had a leisure time in Vizag. So the child, now I saw the child. We tested everything. Normal lungs. Even the peak flow meter is normal. Everything is normal, but child is continuously coughing. I thought some depression or anxiety, so I've given some medication, like that Nexito LS. After 4 days, again the child was brought. Repeatedly they were bringing out that the cough is not relenting and patient is breathless. Then I had to admit him. I showed to a pediatrician, myself, and a psychiatrist. Finally, a psychiatrist could sort out the problem. He is given QT-pin, Nexito, not Nexito LS. He was given plus. That means double strength, clonazepam with acetalopram, and QT-pin was given. And mother was taking care of consoling him that your father aspired you to be an IITian, and now you are in a Chaitanya IIT primary course. you focus on that. That's how there was a support from the family and medical support from the psychiatrist, and slowly the child recovered. That is the second story. And third story, yesterday night only, one of the chemical engineering professor who was admitted in COVID ICU, they were known to me for the last 35 years. And his son rang me up that, again, a bizarre behavior and irrelevant talk. The nurses are complaining. They asked me. I again went to the ICU and sat beside my father. He is refusing to use the oxygen, and father is saying that nurses are scolding me, nurses asking me to go and sleep in another room. So even as a son, you are also not listening to me. You are not cooperating with me. This is the third scenario the boy has said. So these are three scenarios you have to enlighten. And finally, from the administrator's perspective, as Dr. Sudhakar said, I'm a member of state expert committee, and we used to sit down and make policies. In that policy making, actually, Dr. Vinod Kumar IAS, who chairs our sessions, he focused on mental health. And actually, we took a cue from Assam. So the government of Assam, the police of Assam, and Guwahati Medical College, and the clinical psychologists there, and social psychiatry activists, all of them, they had one, forum like Manognya. Manognya is the forum. And actually that was initiated for Brahmaputra flood victims who lost their lives, who lost their properties, lost everything. And a lot of psychiatric cases were emanating, people with depression, anxiety, and flurry of suicides. That's why initially it was, it began with Brahmaputra flood victims, and then that was extended to COVID-19 victims as well. So we had an opportunity in the meeting to interact with the Guwahati professor. I couldn't recollect her name. Then they said they formed a teleconsultation. Every day they used to ring up they gather the information from the state government, who are admissions in the wards, and they used to talk to the patients every day. The form works from morning 9 to evening 9. Then we took a cue from them, and government of Andhra Pradesh also designed 104 Manodhairyam. That is a teleconsultation forum. Actually, if everyone knows that 104 is a single stop call center for everything, for counseling, treatment, or psychiatric counseling, all those things. So Dr. Indla from Vijayawada was entrusted the work, and he is the chairman. He prepared a list of willing psychiatrists and clinical psychologists and social psychiatry workers. And that forum is, I think, it's operational. Actually, once that was handed over to Dr. Indla, I stopped focusing on that psychiatry thing. So the last point what I wanted to say is, if people visit the website of Ministry of Health and Family Welfare, Government of India, there is a 177-page document written by NIMHANS doctors that mental health in COVID times. It's a wonderful book, chapter-wise. So the problems were dealt: child psychiatry, adolescent, adult, when they were away from the schools, they're away from their friends, their play, how they behave, how they are addicted to their gadgets. And, it's also addressed pregnancy, postpartum psychosis in relation to COVID, and smoking, alcohol withdrawal, and domestic violence in times of COVID, what psychiatric problems the husbands might have been going through because of their job loss, income loss, and thinking about the loss of education of their kids. And another chapter, how to deal with an aggressive patient. COVID people in the ICUs and wards, sometimes they turn aggressive. So all these people, and then ICU psychiatry,
and then one chapter mentioning minimum basic psychiatry for general practitioners and for pulmonary general practitioners, where they have mentioned how to deal with delirium by using the small medicines, like they have suggested haloperidol, QT-pin, olanzapine, like that, and for anxiety and depression, that SSRI inhibitors, sertraline and escitalopram. So that was a wonderful document by NIMHANS people kept in the website of Government of India, Ministry of Health. And finally, the Government of India has floated another forum, that is Kiran. The Kiran is from the Ministry of Social Justice, where it also floats a tele helpline for the mentally upset people. So this is what is from my side. Bush, I've explained you three scenarios. One is stigma, another ICU delirium, and another is the child. I don't know what I should call it, whether it's a conversational hysteria mimicking his father's asthma or what, I don't know. And it is for you to throw light on this. Thank you so much.
Thank you, Prem Kumar. I think you hit it on the nail, because the last reference you're giving from the National Institute of Mental Health and Neurosciences, NIMHANS, they are definitely experts. And I think I would rather look at that, because they probably know the Indian scenario. And what you're mentioning with the ICU situations in the beginning, it could be ICU alcohol withdrawal, or it could be related to hypoxia and encephalopathy. And so one thing is, we can have algorithms in terms of how to handle them and how to recognize the delirium early. And probably that's I hope that was mentioned in that in NIMHANS in their book, what they're talking about. And still we use haloperidol, we use these second generation antipsychotics like olanzapine or quetiapine, but only IV, if you are not to give, we give IV haloperidol. The rest of the antipsychotics we don't usually give. And the other aspect of when related to one more thing you mentioned is related to the providers and how to handle their level of stress. But I really look at all the people in this forum, most of you had shown a strong resilience. You guys all bounced back. And it came probably with years of your experience. And you guys were all in the war field for last 1.5 years. You were like soldiers. And even though people were dying, you got to go back to work the next day. You have no way you can say, I won't do it or I can't do it. You may had probably an opportunity to say, I can't do it, but you kept on doing it. That's part of the strength you all had, and you displayed it. Now, how we can probably make everybody ready for this kind of a thing? Definitely at the organization level, everybody was caught off guard when this COVID came. So nobody is prepared. Same thing happened in Italy, same thing happened in New York, same thing happened in Visakhapatnam too. But especially with our situation in Visakhapatnam like that, once you know what you're going to do, how can you help these providers is have them a kind of first of all, you need to accept. You did a wonderful thing that if anybody says, I never had anxiety, I never had a panic attack, I never had depression, they're saying a big lie. You're absolutely right. And coming from you, it has a strong impact because you are one of the senior professors. And when you say this is possible, then people will look at it, okay, there is no need to deny the stuff. Not every anxiety, not every depression, you need to have an antidepressant given. Most of it is accepting I have a problem and I won't be judged by it is good enough. Now, you mentioned some of the programs from the Gauhati Medical College and from the Government of India. Like, actually, this is a forum where we are talking loud, we are thinking loud. I shared my losses in my family. Shaker shared his losses, and you are sharing your, like, personal what happened, because there was no person in this room that did not lose a loved one during the COVID, maybe more than once or twice. So we're all in the same boat in this. To develop resilience is communication with the staff members. How can you improve the communication is the forums you have to develop locally. And if you have, this is a kind of a forum where you can invite people and discuss these kind of issues. Because I was talking to Shaker yesterday, I call this emotional dialysis. Just you listen to the patient. And I mentioned also in one of the forums, I call it listening skills and validate what they're going through. Yes, it's very, very sad that you lost your dad. Sometimes I say, I don't know what to say. This is so severe situation. I don't have an answer. But at the same time, we are telling the patient, I hear you. So even same thing with the staff members. Sometimes they have concerns, they have grievances, they want somebody to listen to. So if you have any kind of a situation, if you have any forum where you can improve the communication between the interns or the residents or the fellows or the staff, that is one barrier you can address that. Then some of them are system-wide, but you're already, like, from the AP government level and national level, you are already addressing them. And I think the other one you mentioned about is the patient with the COVID coming with the panic and, the pulmonary clinic having patients with the panic and anxiety, but they're complaining, I can't breathe. And once you run all the tests, you say, this is a panic attack. And when we are comfortable treating with them with an antidepressant and a benzo for a short term, that is, you're doing the real good thing to the patient. Only with the people are scared with the benzos is that if you give for 6 months, then you need to give forever. So probably that needs to be kept in mind, that you don't want to see that patient is not misusing. But I like what you have mentioned is that you are comfortable prescribing anxiolytic and an SSRI and handle because if it comes from you, probably the patient believes it more rather than asking him to go to a psychiatrist whom he never seen before. So one of the advantages the primary care have is they have the confidence of the patient with them. The other thing what you mentioned, the boy who lost his father with asthma is, as you said, it is, you can call it somatoform disorder, and you can call it a conversion because he's feeling the grief. And he has basically taken the symptom of the father and he's repeating it. And the psychiatrist has treated him with an SSRI and a quetiapine and with maybe a benzo to reduce the anxiety level. But most of it is talking to the patient and letting them grieve the situation, the main conflict what they're having. If he can talk about how bad he's feeling about father's death, and then probably things will settle for him down the line, he would probably need the medicine. And you mentioned another person is that teenage who lost the father for bronchial asthma. No, I think you mentioned about your daughter's friend whose father got admitted and who rather they stopped all the psychiatric medication. It's not unusual. Whenever they go for surgery or whenever they go for any hospitalization, if the patients don't tell, sometimes they don't get started and they have a relapse. They get treatment for the medical issue, but they have a relapse of the psychiatric issue. And once you restart them, you could have addressed that. I think I would say that having a telemedicine, like you mentioned about it, definitely you can use it in ICU level also. Right now we do that with the COVID, even for the emergency room, some of the psychiatrists are doing a telepsych consult. They have the computer with the screen, goes in front of the patient, and they will talk, and they're doing it. In ICU setting, I think it could be consultation for the physicians who are in the ICU, and the psychiatrist could be on the other side. And I think we have a lot of alumni, and we wish to volunteer if it could be officially done too. Rather, we can have consultation, we can have CMEs, how to address these kind of things from various alumni, both in India and also here. I think that is my main take, and if anybody's interested, I can pass on the toolkit. I have that for the primary care. Same thing, like you said, NIMHANS, they have addressed a lot of the issues, how to treat mental illness in a primary care, how to treat psychosis in ICU, and probably that it may have a similar algorithms. I think probably here they use what you call a confusion assessment method in ICU setting. And they use a Richmond Agitation Sedation Scale, RASS, to see the nurses are trained if the patient is having any waxing and waning of consciousness or any altered behavior. The guy walks in normal, but suddenly they have these kind of symptoms. So nurses easily catch, and they inform, hey, this guy is going into delirium. So before it's a full-blown delirium, you can catch early. And then again, you as any ICU physician knows, polypharmacy could be sometimes, and excessive sedation could be sometimes, or sometimes not starting the medication could be because of the delirium. I think Dr. Chilmuri, I see him on the screen. I think he can probably talk about from his department in terms of ICU management of the CAM and the RASS, if they're using, obviously they're using it, and how it could be translated into our practice in Visakhapatnam.
I think they use that in Vizag also, I think. But in terms of, let me go back a little bit in terms of COVID itself. First, I think when you see these, what you are categorizing as psychotic or psychiatric illnesses, the first caution that I would have is that COVID itself causes many neuropsychiatric symptoms, and they could be in the acute phase and the post-acute phase, and maybe 3 months later too. So I think when you're faced with patients who are having these various neuropsychiatric syndromes, you want to make sure that there's no organic cause for it, because I think it's always confusing to make these diagnoses, whether it's depression or anxiety, because you're dealing with people living in a pandemic who are already stressed because of living in a pandemic. There are economic and social stresses on them. And we don't know how much of the whatever they are facing is because of the acute illness or because they're already suffering from the lockdowns and the economic hardships that they're facing. So it's very difficult to delineate one versus the other. But I think you as a clinician, you should not miss that there are neuropsychiatric syndromes that COVID causes. First, if you look at the stroke syndromes that you get in COVID, of course, you get the large vessel strokes like any other stroke, but there's another distinct syndromes where you get microvesicular emboli, and they're very deep in the limbic system. So patients present with kind of acute, bizarre behavior and doesn't mimic any stroke syndromes that you normally see. And they're often categorized as having acute delirium, maybe acute illness delirium, or an acute psychosis in the ICU, things like that. But it actually may be just microembolic phenomena with deep limbic strokes that COVID causes. And so that's one thing we need to keep in mind. They do get encephalitis of various kinds. Again, they are quite deep. Sometimes the information is not so superficial. So it's not uncommon to see a normal CSF protein and still have encephalitis, which is sometimes very difficult to diagnose unless you do an EEG and find a distinct pattern. So that's something also to bear in mind. And in terms of the another pattern that we're seeing as we're interviewing particularly healthcare workers who got infected with COVID and following them over a period of time, there are 2-3 patterns that emerge in them. This is 3 to 4 months after they recovered from COVID. I'm saying healthcare workers because they're most knowledgeable, so we tend to get more detailed information so they can explain in additional details. One is word finding. They suddenly lose a memory of certain words that they normally use, and they get stuck in sentences when that word suddenly comes, and they can't move any forward, and this causes them extreme anxiety. So a common word like maybe an animal or a food item or a breakfast item, you get stuck in it. What did you have for breakfast? And you can't remember the word eggs or omelet. And that causes enormous anxiety, and you can't function after that. And this appears to be after they're coming from COVID. And the second one, which raises this issue of this unfortunate person who jumped out of the building, is this inability to suppress the irrational thought. So we all as human beings are constantly get irrational ideas, but we have the ability to suppress it. For instance, if you're on a tall building, you could look down and say to yourself, I wonder what happens if I jump out of it. But immediately you know how to suppress that idea and you don't jump up. But post-COVID syndromes, we're seeing patients who report that they get these irrational ideas again and again and have an enormous difficulty to suppress it. And some of them have actually acted on those irrational ideas, like jump out of buildings or commit suicide or played with a gun and then say, what happens if I shoot myself, and eventually shot themselves. So these are quite unique COVID syndromes that we're seeing. So I think I would recognize them. I think whatever Dr. Bush mentioned about the other aspects of psychiatric illness is a distinct, separate, be managed. But I think the neuropsychiatric syndromes that COVID causes, I think we need to identify them because they will be treated differently. Some of the same medications may be used. I think a patient will be more satisfied if we recognize this is your diagnosis and you're not just feeling anxiety because of the pandemic, but rather this is what is happening to you, the post-COVID syndrome, and we'll figure out how to manage it. I think makes them feel a little bit less anxious and a little bit more secure, and they're willing to participate in whatever treatment regimes that you're planning to do for them. And the last one is insomnia is very common post-COVID. And sleep deprivation has its own unique challenges to deal with. And that's a separate syndrome also we need to recognize. So maybe sleep studies are needed in them after COVID. If you recall that during COVID, many of them lose enormous weight, and because of the steroids, and as they recover, they rebound and become not just gain their own weight, but actually gain a lot more weight, maybe 20, 30 pounds more than what they lost. And that leads to other issues with sleep apnea and sleep disorders. So they develop a new raft of these disorders that we have to look at. So those are my comments as it relates to the neuropsychiatric manifestations of COVID. In terms of general effect of pandemic, what we have done in the United States, I think mental health has deteriorated enormously in the last 1 year, particularly in younger people, more so than older individuals. When I say younger people, I meant people between 20 and 45 or 50 years of age. I think the effect of they are suffering enormously. Those who already had underlying various addictions like alcohol or drug abuse, that has increased many-fold. If you were drinking alcohol to begin with, now that situation has got a lot worse. So intoxication is more common, withdrawals are more common. If you're doing drugs, then drug overdoses has gone up enormously. So when you screen them, so we now always screen them minimally when they came to the hospital about depression, but we've now expanded that. So we take the usual depression scales. We use the, the 9-point scale to find out if there's any signs of depression. But we also now started using 3 or 4 additional questions. One is, number one, if they recently have been laid off from a job or had to change a job because of the pandemic. 2, we asked them about food security. If they, compared to 2019, is there any more difficulty that they're finding to put food on the table? You will be surprised how many who were in the middle class not too long ago are now having difficulty in putting food on the table, even in a wealthy country like United States. And third, we asked them about recent losses of family members, either death or serious illness in their own family in the last 1 year. I mean, we asked for 1 year because of the pandemic situation. And any of them, yes, we automatically have a psychiatrist see that person and do a more detailed evaluation. Because we as internists have some training, but certainly not anything that we can, because it's often when we try to get any more information, we tend to hit a wall, and that's when a psychiatrist has to come in. So any of these scales come positive, we're asking a psychiatrist to see that person in the hospital before they go home. Because we had one person who actually hung himself in the hospital, looked perfectly okay, got admitted because of a non-COVID situation, listened to everything, came in for chest pain, had the appropriate workup, agreed for a cardiac cath, and on the day of the cardiac cath hung himself in the bathroom in the hospital. And that told us many things, that they'll say all the right answers, and an internist doesn't have the training to pick up the subtleties in that person's life. So we added those additional screening, and I think it would apply to any country. I think India can also screen everyone that comes around and look for these other stresses in their life and recognize that can lead to an adverse outcome. Those are my comments.
Thank you, Dr. Chilmuri. I think you have really highlighted one aspect of how the knowledge is being shared, because as a consultation licensed psychiatrist, if I see that with the COVID, they're having microhemorrhages in some of the vessels in the limbic, then it is leading to, it is a new kind of a disease, and we are finding new symptoms. Not that we haven't seen any strokes before, but in the COVID, acutely, this is a kind of an viralness presenting. It would make you look at the management. Are we going to address it the same way or differently? How long it's going to last? What are the long term? What are the short term kind of a thing? So it's all knowledge we are gathering about it. And I think Dr. Chilmuri mentioned about what as a primary care we can do is that I think the fundamental is anxiety and depression. But for you to refer to somebody, you need psychiatrists or social workers or psychologists who are willing to do some counseling. And we have very few number of psychiatrists available in India. So I think the onus, unfortunately, still falls on the primary care. And I think, starting an SSRI, something would be really like, they could do some good to the patients. Or at least ask them in follow-up appointments, how you guys are doing, are you seeing a psychiatrist or not, like Dr. Prem Kumar mentioned about his patient. Now, Dr. Chilmuri also mentioned in the end about the grief related to the issues, losing the family members. And I was talking to Dr. Malleswar yesterday, and I think, he was sharing an experience about how he's emphasizing the single parent that is surviving and with the whole family, and what kind of challenges as a busy practitioner he is seeing. And Dr. Malleswara, can you share that and pitch in?
Yeah, one of my brother's classmates is a actually medical representative for the last 25 years. He had COVID and was admitted in Care Hospital Vizag, and he expired. And nobody is there to take him to the burial ground even at the time. When my brother himself took him to the burial ground and did all the cremation and everything. Even to do the ritual, the karma cheyadani kuda evaru ledu. So he himself went there and did something. And you think about the financial aspect of the family. She is a moderately educated female without any job. Husband lost a private job, and they spent around 8 to 10 lakhs in the hospital. And how she can survive? Now she went to her parents' house. The child was once studied in good school. Now he is in village, and they brought to me that boy to me.
Can I just stop you for a minute? And is there really an earthquake in Visakhapatnam, and is that true? And if you're all safe or not? I don't want to continue if you guys are in danger.
No, Dr. Chilimuri, I felt a quiver under my feet, on the floor. And somebody, Dr. Gopi mentioned that there was an earthquake, but I felt very clearly. Still, I am upstairs only, but...
Okay, but we are all safe, right? So we can continue.
It should be a minor one.
Okay.
Minor one. All of us.
Okay, I think we can continue because I don't want to ignore if you people are in danger. We're not here. We're safe here. So, okay, please go ahead.
Yes. Now think of the child's mind. He was in Vizag for some time. Now he is in small place, and they brought to me. He's so sad. He's unable to study, unable to concentrate in his studies, and like that, there are so many stories. And one of my classmates, he's a biochemistry professor in Vijayawada. He expired. From the day of his diagnosis, he was in touch with me, and I followed him. Suddenly, with the ventilator and this thing, he fell down from his bed during the night and he expired. And his wife was narrating that they did not allow me to stay along with him, and otherwise I would have saved. Even now, after 6 months, when I call her, she is telling the same story. Malasa garu, nenu aa roju untunte ma husband chanipoyavalandi. Goes on repeating the same thing. Like this is happening in so many families, and there are so many financial losses during the acute phase. During the acute phase of rampant COVID, we used to see people who recover having a lot of anxiety, depression, and feeling breathless, palpitation, as Prem Kumar said, and some people telling about their chest pain, everything. Now, slowly these complaints are coming down. Now, only people who, the relatives, they are coming with many, even minor symptom. They are feeling afraid. Even for simple flu also, sir, my family lo chanipoyarandi, ippudu naaku flu la naaku fever vastundi, cough vastundi, is it not COVID? And in nearby my place, one doctor is there, is a surgeon. He lost around 6 people in his family. 6 people. His chinnanlu, peddanlu, uncles and everything. Even the doctor, if he's having small flu, he's coming to me, sir, I'm having cough, fever and everything. Is it not COVID? He almost got rapid COVID test 6 times. So this kind of panic situation is there in some families, and some families are financially broken and jobless. The children are almost orphans. We cannot explain how they are managing, how they are society, how we are able to help them. It's a very big task. Now, Bush, can you explain how we are how to support, how we are to counsel them?
Again, it's really a tough situation, and this is going to unfortunately continue. And I think there's one question from Sri Ganesh: how common is the PTSD in the family members and the COVID patients? And it is going to be very common, especially, as I said, the anniversary reactions like that. And again, you talked also about the fear, because people are oversensitive now. And I think they're going to look everything with a microscopic view. Any small symptom, they're worried, am I having a COVID? And I think, however, still what we can do is give them the right information, give them the information and let them be educated. And I think correct knowledge probably would help. Again, vaccines, definitely I know that vaccination is really picking up in India. And I hear door to door they're going and doing the vaccinations, as you mentioned, Malleswara.
Yes, yes.
Again, as I mentioned before, if they are depressed so bad that they are becoming suicidal, I would rather start antidepressants. And if they are not to that point, then obviously it's talking to them, what we call psychotherapy, or just listening to them. Sometimes they want somebody to listen what they're going through. And in the primary care, we don't have that much time. And going forward, what we can do is probably we need to use other forces, like medical students in the hospital setting, in OP setting, if you have, and give them some skill, listening skills, teach them, the medical students, so that if somebody is presenting with that, the student can go and spend time with them, because a PG or a fellow or an attending may not have the time. And also probably recruit social workers and the psychologists into the mainstream, and so that they would be able to run some groups. And I think, group therapy would be one of the things could be done in India, especially now Zoom is there, and we have to use all the resources we have to address the grief issues. I was talking the other day also about it. We have the rituals in India, and not every person does the ritual. Dr. Malleswara was mentioning some of the families, they have the rituals, they do monthly rituals, annual rituals. It actually helps the grieving process. In a way, if you look at it, they cannot help it, they have to do it. They don't want to do it maybe, but while you're doing it, they're able to express what's going on, the pent-up emotions, the crying and everything. And if you see it over a period, the time heals, they call it. But I have seen in families, these rituals are helping. They're going to Benares and Astikal Kalpadam, Abdikal Petadam. And they're doing the services in the memory, like Annadana change now. They are trying to grieve in various ways, and we got to be really creative in our Indian scenario. And there should be a kind of most of the physicians are the thought leaders. You are the ones seeing it, and psychiatrists, and probably you can address that. It depends from area to area, especially private practitioners. The families, that. And I think probably NIMHANS, and I think also the Institute in Ranchi, they're also talking about some social psychology interventions in these aspects. I think, Dr. Kairam, how are we doing with the timing, sir?
We did quite well. I must ask forgiveness for having to leave the stage. Dr. Sudhakar is back. Usually we stop around this time, Dr. Bush Garu. Is Sudhakar back? There's one more question from Dr. Radhakrishnan. Go ahead, speak, sir. Okay.
So good morning, sir.
Okay.
Yeah, I am Dr. Saumini. I am a Professor of
Good morning.
Obstetrics and Gynecology, Dr. Krishna. I'm sharing both of us. Actually, what happened is, medical education, I did some on the students who undergone online discussion, online training during the COVID period, where only online teaching was there. And though it is not a psychiatric disease what they had, but they had given the feelings of there's no state of alteration of mind, and around 52% of students have to responded.
Dr. Somani, even I did not understand the question properly. We might be able
Yeah.
to
See,
connect
not
you directly to Dr. Bush
I'm sharing my
separately.
experience of the students who are the medical students.
No.
That,
So many, please
Yeah.
listen. So many, your
Yes.
voice is not clear. So there's some problem with your audio. There's no point continuing. What Dr. Kairam
are
is
you able to
suggesting
hear
is
me,
that
sir? Yeah.
no,
Are you able to
no,
hear?
it's breaking. It's breaking. Okay, you can
Doctor-
reach Bush directly. Yeah.
So we can
Okay.
connect you to Dr. Bush directly, Dr. Somani. Your audio is very
Okay.
poor.
Yeah.
Yeah.
Yeah. With
Doctor-
regards to
Can-
the time. Yeah.
Last few words,
Yeah.
Yes.
actually.
Go ahead, Dr. Prem Kumar.
Actually, Dr. Bush, regarding this community psychiatry, I have 4 issues to raise. One is, we were reading in the newspaper that a family committed suicide thinking that it was. Am I audible? Such news was, very prevalent those days. So what was going through their minds in committing, the community-based mass suicides? Second thing is rogues who deny these strictures and they don't follow the COVID appropriate behavior, in spite of repeatedly telling them, and they know pretty well what would happen if they contract COVID. Still, they defy and they are, they freak out. So, what would be going in their minds? Is there a psychiatric illness for those people who don't listen to and who follow? Vaccine non-believers. What's going through their minds? Any problem with them? And finally, those, you must have read in newspapers that lakhs of people thronging, queuing for the magic remedies like Anandaya and all. So there must be some psychiatric basis on that too. So these 4 aspects: mass suicides, vaccine non-believers, and rogues who defy COVID appropriate behavior, and magic remedies. Would you comment on these things?
It's a very interesting question. And you need to understand, human mind is predominantly filled with your thoughts and feelings, which is predominantly influenced by the external world. What we call mind is basically coming from the outside world. So the first instant you talked about mass suicides or mass hysteric behaviors, because you see, if a famous actor dies, especially in South Korea, you have seen this phenomena. High suicide rate is in South Korea. Like if a actor commits suicide, and most of the fans will try to do the same thing. So it's called copycat behavior is talked about it. And it is a suggestion. A lot of people are suggestible. So there are some personalities who are more suggestible, and it is a twisted thinking. Honestly, we call it a cognitive error. How you look at the world is twisted. So, but somebody has to let them show, hey, you say a broken bone. If some guy is walking with a broken hand, we say, hey, your hand is broken. Are you not having any pain? Similarly, somebody able to show them, hey, your thinking is twisted, correct it. It is not as easy as said and done, okay? So I think definitely there are personality styles. The other thing is talking about the people who are, they know it, but they have a different attitude towards it. and they want things in their way or the highway kind of a thing. So these are all the attitudes people come with and grow. Now, how can you change the attitude? There again, there are different ways how you can. Some people you can talk to and educate. For example, I have a lot of patients who hasn't taken vaccine. They come to me. I talk to them about how the vaccine works. I will talk to them about my own apprehension when I was thinking about it because the COVID is new too. And I will tell them what are my doubts, how I clarified them. I have a discussion. I won't tell them, hey, why don't you take your vaccine, go and take it, otherwise you're going to die. So they want to hear somebody whom they trust, if you're a physician, a neutral kind of an outlook. And finally, I tell them the reason I took the vaccine is so and so and so. And trust me, if I spoke to, in the last week, I spoke to 4 of them, and 3 of them are now considering, they're asking me, where is the vaccine clinic? So there are some people you can help. There are some people hardcore, they say, heck with it. They're in ICU, honestly, and they're almost to be intubated. And when they were told, hey, if you survive, will you go and take the vaccine? Did you hear their answer? No. And I was talking to some of my friends here, hospitalists. We have such a people who are almost had a COVID, they're almost going to die, still they don't want to. So you cannot help some people. So there are various aspects. Some people we can help. That's where I said in a communication, how we tell them. And each of us, as a thought leaders in the community, whatever we say definitely matters. So, and that's what the best I can tell you. But related to I think you asked 3 points. What was the third one? One is about the attitude of the patients. One, you talked about the copycat suicides or a stress suicide. That is again in a panic and impulsivity.
And those people who break the COVID appropriate behavior in spite of knowing everything, and magic remedies and mass follow.
Magic remedy, mass followers is again lack of information and lack of knowledge, lack of right information. Even educated people are falling for it because of the desperation. And we do have a lot of native sentimental thinking related to our own traditions and cultures. Some of them we respect, some of them we know with a rational mind they do not work, but they don't have that knowledge. They think they are correct. So this is a rooted wrong core belief. That's what I call it. We run our lives based on what we believe in. So our core belief structure was built like that. Can you change it? Only you can change it through thought leaders. That is why we need to say, if in a community, if there is a thought leader, it could be religious or spiritual or scientific, you have to reach out to them. And if they go, vaccines will help, go and take it. There are Ayurvedic medications for some, but not every Ayurvedic medication has the ability to treat complex situations like COVID. But we had a lot of people, like, chemical engineers became COVID experts because they can read and vomit it out. Doesn't make them the experts. But unfortunately, we have 2 billion people and maybe not so many million doctors there.
Oh, thank you, Bush.
Yeah, thank you, Prem. Very interesting questions.
Yeah. We will have the final word with Dr. Sridhar and then close the session. Another 3 or 4 minutes by Dr. Sridhar.
No, I have nothing much to add. I think Dr. Bush covered it well. To Prem Kumar's question, I think there's so much of need here. So I would focus on people who really are in need and not worry about people who don't want to take and fight and all sorts of things. I think we have enough work for ourselves to take care of people who are just recovering from COVID and suffering from post-traumatic stress disorder and things like that, and families who've been devastated by loss of loved ones in their family. I think all the support that we have, we need to focus on them. And the people who are out there still are COVID deniers and all the other stuff that goes on, I think their time will come at some point. But right now, we need to focus on the people who really need help. And that's where I would spend all my time on.
Thank you, Sridhar.
Yeah. Ram Mohan, are you there? Yeah.
I think
Is
Dr.
there anyone?
Sudhakar,
Yeah, somebody's talking. Yeah.
I think there was
Go
one
ahead.
question from Dr. Somini. She's asking about some of the students for the online teaching, they're feeling anxious and they're having depression kind of a thing. It is across the board, middle school, high school, everywhere. The social isolation has caused anxiety and depression. Most useful thing is support to family members and listening to them. If you listen to the student, what going through, there is a room for them to ventilate and express their frustration. That is a simple thing we can do. No need for any kind of a psychiatric consultation, no need for any medication like that until unless they become dysfunctional. But it's time to sit down and listen to the kid. Whether you could help or not, that's a different thing. Just listen to them. Thank you, Dr. Sudhakar. I'm done.
Yeah, good. Thank you very much, Bush, for those final words. And thank you all for such an interesting session. So now this is rather experimental at having not a didactic lecture or the lecture that we had earlier, like what we had. Discussion has always been an important component in this particular forum, and that's what has thrown light many times. And this time we thought that we will have a different format, and it has been quite successful. That all the three participants who have posed questions have covered wide range of issues that they have actually encountered, the real lifetime scenarios. And thank you very much for so aptly answering them. And at the same time, the way the discussion went on, it's clear that we are going to have this problem in future as well. And probably we might require many such sessions to tackle these problems. So to have the real life scenarios is very, very important to be discussed here. And I thank Dr. Kairam for suggesting this particular format and also for choosing the right persons to pose questions. And I sincerely thank Dr. Sridhar Chilumuri for having chipped in and given his input on this particular topic. Thanks again, Bush, for your expertise, and come back again whenever you are needed. Thank you all. Have a good day, all those in India, and a good night to all those who are in the United States. Bye-bye.
Wonderful.
Thank you,
Talk
sir.
to you.
Bye.
Thank you, Sudhakar. Bye.
Bye.